back. So I'm going to walk around so everybody's in the front and everybody's in the back. Okay? Keep everybody interactive. I wrote a couple of numbers up there. And what I want to do today is I want to cover the numbers on the board to reinforce some of those. But also what I want to do is kind of validate and help you guys understand why we do what we do. Okay, why do you use this system? What's the value, what's the benefit, not only to your patient, number one, because that's why we're all here, right? But number two, to you guys as the staff in the room. And number three, your physicians that are doing the procedures. And then number four, the hospital and the hospital system, right? So let's make sure we understand why we're doing it. Because a lot of times you do things, but maybe you don't understand why. It's just, well, that's the policy. That's the next thing I have to do, right? But if we understand why, maybe we do it better, maybe we do it more rigorously. Maybe that's the right word. But anyway, that's kind of what I want to discuss today. And then I want to spend a fair amount of time with questions, okay? Because if you guys have questions, let's get them out today, and let's make sure everybody is doing things the same way, the right way, so that we're benefiting your patient, which again is the main reason why we're here. Okay? So this side of the room, and I'm going to go right down that table between you two guys there. Who thinks they know what the 77% might mean? There's no wrong answer, but there is one right answer. Anybody on this side of the room think they know what 77 stands for? Go for it.
I'm going to take a wild guess.
I love wild guesses.
The number of procedures where there has been a retained sponge and the count was correct in the room.
Wow, that's a great answer. It's not the right answer, but it's a great answer. But you were really close though, okay? The number especially. So this is what you're talking about, which is, I think, a very eye-popping number.
Oh, yeah.
Okay? So thank you for bringing that up. This side of the room is clearly the A students. Okay, so 88% of the time there's a retained item, not just a sponge, but an item. Okay, it could be a piece of metal, a grasper, a burr tip, a needle, whatever it may be. 88% of the time that somebody has a retained item and it's identified, and usually that's identified 5 years or later, they go and look at the chart and they say, oh, the count was correct. Okay, that's a really good point. Thank you. All right, this side of the room. 77%. Who wants to make a guess? That's a really tough one to the top, that's for sure. You might want to throw it out? Okay.
Infection?
Say again?
Infection?
No. Great. That's a good point though too. I'm not going to put that percentage up there, but that's a great point. It's not an infection rate. And it is, if I remember right, surgical site infection, I want to say is 83% of the cases there's a retain. I think that's part of it. I may be off a little bit on that one. The 77% represents, and don't take this the wrong way, this is why we're here today, how effective the manual count is. Okay? What you guys do every day in your cases. It's 77% effective. And I think we would all agree, hey, I can count to 5, I can count to 10 as well as anybody, right? That's not the issue. The issue with that 77% effectiveness for a manual count is that you're not just counting, right? And you're not just counting sponges. You're counting instruments. You're maybe answering a page that a doctor got. Maybe somebody just relieved you for lunch or a break. Maybe the robotic case just went open. We've got to undock the robot. We've got to bring in new trays. We've got to open up things. We've got to count more things. Maybe it's an emergent case. Maybe we've got to pack a patient. Do we have time to count? No. Right? Maybe it's multiple procedures. That's a huge risk factor in retained items, multiple procedures, okay? So maybe the urologist just came in and did his part or her part of the procedure, and now the general surgeon's coming in to do maybe a colon resection, whatever it may be. Okay? Multiple procedures are a major factor in why retained items occur. And 77% of the counts are found to be accurate overall, okay? Again, not an indictment on what you guys do every day, just reinforcing the point that a lot happens in a single day in a single case. Now, if there is a miscount, anybody want to guess the percentage? Well, no, let's not even say percentage. How many fold, maybe we'll say it that way, how many fold increase is there in the likelihood of a retained item when there's a miscount? I'll give you a hint. It's either greater than 5, it's 10, or it's greater than 15 fold. Anybody want to guess? This side started up pretty strong. I'll give you guys the first chance. Greater than 15. This side?
Yeah, so the same.
10, right here. 10. 10-fold increase in the odds of a retained item when there's a miscount. Okay? Now, if you didn't have our system, okay, what's the standard of care when you cannot find that missing sponge?
X-ray.
X-ray. Anybody want to guess what 67% represents?
Probably because they find it, or don't find it.
So you're all saying the same thing. 67% of the time there's a retained item, not just cotton, but any metal or whatever that item might be. 67% of the time, X-ray finds it. And everybody, I kind of get the eyebrows raised when we say that, but everybody thinks, well, that's the backup, that's the standard of care, right? X-ray should be better than manual counting, right? Should be, you think that, but it's not, okay? Now, think about why. Who's reading the X-ray? Is it the doctor? Is it a radiologist? Is the radiologist here? I have shown images of, X-ray images to doctors, and I would say, there's the sponge, and they would say, Scott, if you told me that 100 times and let me look at this for an hour, I would never say that that was a sponge. It's hard. It gets wadded up with blood, it gets behind an organ, it gets behind a bone, there's just a lot that happens in regards to variability when you look at an X-ray, right? So 67% of the time, an X-ray is going to find it. So that means if you take 3 X-rays in a day, one of those patients, you're missing it, statistically, okay? So I say those two numbers, and we talked about those two numbers for a couple of minutes, just to reinforce the fact that this is why you guys use our system, okay? And again, it's not an indictment on what you do, and it's not an indictment on X-rays being 67% effective, and the variability of whoever's reading it, but it's basically, there has to be a better way. Okay, how long has X-ray been around? I don't even know the answer to that, but it's been around for a long time, right? How long has nursing been counting manually? 50 years, right? 60 years, I don't even know the number. But it's been around for a long time. That's been the standard of care. Well, there hasn't been anything out there since that makes things more accurate. And that's where this guy comes into play, okay? Now, Medtronic now owns this company. I don't know if I said I was from Medtronic. RF Surgical is a company that invented the technology. There's a doctor out of New York that came up with this, Dr. Jeffrey Port. But Medtronic now owns the company, and Medtronic's putting a lot of resources behind this, because one of the first questions I know you're going to ask, so I'm going to try to be proactive, is, hey Scott, when are we going to be able to detect metal, right? Everybody wants to know, can we detect needles with this and all that? Not yet, but it's coming. But today it's cotton, and that's what you guys have been doing. Okay? So, next question. What does a 16 represent when I say 16 minutes? I'm going to break the room up this way and this way now. So, let's go right here. Hold on. Right here. You guys are now the front. 16 minutes. What does that represent? Anybody, any guesses?
How much time you spend looking for items that are missing on your count?
Wow. That's so close that I almost want to give you a ding, ding, ding. So close, but you were just right there. Okay, how about this back half? 16 minutes. Think of what she just said and look at it a different way, the opposite way. Not how much time you spend, how much time you save. So, 16 minutes is what's been studied, the amount of time that you save using this to find that missing sponge. Okay, so you're thinking the right way. We just had to spin it on you, that's all. So, raise your hand if you love digging through the trash. Who loves bioburden, right? Nobody does, okay? So that's one of the huge benefits of this system, is that I can take this, and has anybody had to wand the trash can yet? Or linens, right? So the idea behind this is if we can save you 16 minutes because we helped you find this quicker, we've added a lot of value to what you guys are doing, right? So that's another reason why you use it, okay? 16 minutes worth of savings, and that's on average, okay? It's not every case. Sometimes you find it in 30 seconds, and we've saved you that much more time, okay? But on average, it's 16 minutes per procedure. Now, let's talk technical. Forget about finding the missing item in the environment, under the OR table, under a foot pedal, in the trash of the linen. What does 2 to 3 minutes represent? Going to this side of the room now. 2 to 3 minutes. Think about technique. I saw your lips move, but I didn't hear anything come out. What'd you say? All right, come on. Somebody's got to give you a guess. 2 to 3 minutes. What does that represent? Think about using the wand. you're on the right track. You're like this answer over here. You're so close. So I'm going to give you. But you got us a step closer, which is super effective. All right. So now you guys have the easy task of taking 2 to 3 minutes is how long you scan, or two. I'm sorry, I totally lied to you guys. 2 to 3 seconds. 2 to 3 seconds. I got stuck on minutes. 2 to 3 seconds. So you're still close. 2 to 3 seconds. What do you guys think? 2 to 3 seconds. Using the wand. You're on the wrong side. I can't see. You gotta be on this side.
Is the average time the wand's used?
Okay, average time the wand's used. So close. So you guys are both on the same thought process. So when you scan a patient, okay, with this, so we've draped it now, right? 2 to 3 seconds is how long it should take you to change direction. Okay, so here's our patient. We're scanning. I'm going to scan over here so I don't get blinded. It's 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. 1, 2, 3, 1, 2, 3. Okay, got it? 2 to 3 seconds, then change direction. Okay? Now, 10 to 15 seconds. What does that represent? Say it again in the back.
The whole scanning process.
Whole scanning process. 10 to 15 seconds. Okay, now, hopefully that makes sense because we just said how long is it when I change directions? 2 to 3 seconds. So it's 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Depending on where you're operating, 1, 2, 3, 1, 2, 3, 1, 2, 3. Okay? So that whole process needs to take 10 to 15 seconds. So, been a super long case, multiple procedures, it's 5 o'clock at night now, everybody's dog tired and we just want to go home, right? Or just get done with this case, right? I need a break, I've been on my feet all day. Yep, we're done. What's the code? Good? No, not good. Okay, why not? We didn't take 2 to 3 seconds to scan the incision or the area that we're operating. We didn't take 10 to 15 seconds total. And you know what? We did our patient a disservice because we didn't provide them with the extra layer of safety that you guys have used and offered every patient by using this system. We basically put this in the room and didn't use it. Okay? Bless you. Okay, so it's got to be 1, 2, 3, change directions. 1, 2, 3, change directions. The easiest way for me to remember in my 4th grade brain is a basket weave. Back and forth, back and forth, back and forth, and back and forth like a basket. Some people say a W, some people say a V, whatever you want to use to remember, but just 2 to 3 seconds back and forth, 10 to 15 seconds overall. Make sense? Okay. We've used all my numbers, but I still have a few. Let's see, so remember 2 to 3 seconds, remember 10 to 15 total, and then the last thing when it comes to scanning a patient with the wand, remember these 2 words, actually 3, but if you remember 2, that's good. Low and slow, okay? Now, low and slow means, we can use the 2 to 3 still, within about 2 inches of your patient, okay? 1, 2, 3 within 2 inches of my patient. 1, 2, 3 within 2 inches of my patient. Now, why would I say use this within 2 inches of your patient?
Because it only detects up to 16 inches and you want to get as close as you can.
You stole my next question. How much is the range? What's the range? 16 inches, right. So 16 inches is roughly that, the height of this hoop wand. It's about 16 inches, okay? So if the patient is up to here, and I've got a 16-inch range, I want to make sure I'm within 2 to 3 inches of that patient to maximize the range of the wand, okay? Now, you still did leave me another question though. What's the range of the mat?
16 inches.
Who said 16? You're on a roll. All right, 16 inches as well, okay. Now, anybody know how the mat works? No? Okay, so when I push scan, okay? So I'm going to push scan. What's happening right now? Anybody know?
It's going back and forth across the length.
It's going back and forth, kind of. Okay, basically there's 6 different antennae in here, okay? And it's basically going in a sequential pattern. It's scanning your patient. And those antennae are basically coming up, like I said, about 16 inches and actually comes out as well. So I don't want to say a cone, but it's a little bit like a cone. So you've got a 16-inch area all the way around your patient. Now, what if the patient doesn't fit on the mat? Not, and I mean the patient's on the mat, but all of the patient isn't on the mat. What do you guys do? Wand. Okay. So now, knowing that, let's say we've got a patient who doesn't fit on the mat. Okay. Knowing all of this, we're going to be wanding within 2 to 3 inches of that patient, 1, 2, 3, 1, 2, 3, of every area that may not be covered by the mat. Correct? Correct. Okay. Very important, because we want to, I call it a belt and suspenders approach. We want to make sure that that mat is coming through your patient, but if there's areas of your patient that aren't on the mat, we have to make sure that we're covering those areas too. Does that make sense? Okay. Any questions?
What if you're doing a gynecology case where the patient is in lithotomy and the operative area is at the very bottom of the mat?
You got the little cutout, and you probably
Yeah,
pull it
do you
back
want
so
to
it's not
use
in
the
there.
mat or do you want to use the wand for
Okay,
that?
great question. And there was another question over here, so don't let me forget. Okay, great question. So if it's whatever position, or whatever procedure rather, and the patient's in a position that doesn't allow you either to have them on the mat fully, depending on the operative site, or ortho, spine, hips, knees, whatever the other extremity procedures might be, you have the wand. And you use the wand for those procedures. Now, instead of the mat, right. Now, the system, just to give you a brief history, the system's been around for about 10 years now. It was invented in Carlsbad, California, from a doctor from New York, as I mentioned. But the system, when it first came out, only had the wand. There was never a mat. Okay? So you can always, always, always rely on that wand. But you've got to do it low and slow, 2 to 3 seconds, change direction, 10 to 15 seconds total. Even if you're doing something in the pelvis, okay, and that patient doesn't fit on the mat, it's not, it's not like you're at church. We're not doing this. It's 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 10 to 15 seconds, and then we're done. Okay. Good question. There's a question over here.
Earlier you had said when you drape the wand, is your recommended practice to drape it sterilely and use it? We've done that at one point, now we just do it afterward. Like after the incision's closed.
Okay, you bring up 2 really good points. Okay, so number 1, what is, today, if you were to do a case right now when we're done here today, what do you guys do, when do you guys push the button on the box, whether it's the mat or the wand? When do you do that today?
After the dressings are on.
Okay. Manufacturer's recommendation before final skin closure. Why? What happens when that skin is fully closed and you have basically finished your procedure? If there's something in that patient, technically, if you found something there, it's a retained event because the skin was closed. So your procedure, and this is, I see you taking notes there, so manufacturer's recommendation is to scan right before, so counts are correct, doctor. Give me 15 seconds to run a scan on that patient before you close. Boom. Now, if you guys are like 99.99999% of all the hospitals I deal with, everyone is super patient in the room and they're going, yeah, okay. I'm all about patient safety, right? That's what they say every day. And they're thinking it, hopefully, but we all know at the end of the case a lot of things are going on, right? So, but you have to do it. Here's why you have to. You have to do it before that final skin closure because it's a retained event. Otherwise, if you find something, okay. So that's something you guys are going to want to consider reevaluating. Okay, I highly recommend that. You had the second part of your question was draping. Okay, so that, you threw me with the draping thing because I needed to figure out when you guys were scanning. So you guys have our sterile drapes, right? Okay. You drape it just like you're draping a C-arm or a Mayo scan. It's the same concept,
I
right?
haven't seen the sterile drape for that in years.
Okay. So if you're scanning the patient because they don't fit on the table, or what if it's a trauma case or the patient has to be packed and they're brought back and the doctor says, hey, I think I got everything out that was packed. Or you're at the end, near the end of the case and you're going to start doing whatever the real operation was, but you had to control some bleeding, so you just lap, pack, right? Hey, can we scan right now? I want to make sure I got everything out. Can you do that?
Yeah.
Absolutely, I highly recommend it, to be honest with you. Because the longer it's in there, the longer you forget about it, right? That time, people will forget what's in there, even though you might have written it down on the dry erase board or marked it somewhere, or whatever you guys do. You can scan it anytime, okay? So, if you scan that patient while the field is sterile, okay, it's not the end of the case where you're, like you guys said, your drapes are down, you want to put a sterile drape on the wand. You're scanning the environment, I'm scanning the trash, the linen, whatever it may be, obviously you don't get drapes then. But if you're introducing the wand into the sterile field, you want to put a strip drape on it. And the wands are reusable, hopefully everybody knows that, right? They used to not be, so I was strip drape. Does that make sense? Okay.
I just have a question. A coworker asked me if the mat is CR.
Yes. Yes. So there's nothing in that mat that is going to affect an X-ray, period, end of story. You can use that all day long if you want. That's a really good question. That comes up a fair amount. Okay. Any other questions? Yeah, go for it.
So we get a lot of patients with a BMI over 50 or 80. If you use the wand, like let's say for a gynae case again, where it was pelvic and the patient's butt's hanging over the edge of the table now. If the wand only detects to 16 inches and the patient's like this big, then what?
So,
When they're thicker than 16 inches.
Yeah.
actually the second comment's actually pretty accurate. So thickness of a patient does not impede this at all. This is a low energy radio frequency signal that is a high or low frequency, meaning like an AM radio wave. Okay, FM radio is high frequency. Your Bovie, you've got blend, and you've got cut mode, like this. We're like this. Okay, we had the choice of radio waves that we wanted to choose. We chose this one because it allows us to go through metal. It allows us to go through bone. It allows us to go through the thick patient. Okay, doesn't impede the signal at all. So, bigger patient, higher BMI, mat, if they're on the mat, right? And that higher BMI patient is not going to affect the mat, okay? Weight is not an impedance to what we're doing. It's not going to affect the performance. But the mat's coming up 16 inches. Any body part, any part of the body, we can wand and get 16 inches. We could go as far around under the butt, the backside, or whatever, right? We can take this wherever we need to wand that patient. So we can go all around that patient. Does that make sense?
So, if you go under the table, will it work through that?
Both ways, yep. Yeah, so the range is if I held it like this, it is 16 inches this way and 16 inches this way. Or 16 inches this way, 16 inches this way. Okay, does that make sense? It's not coming out like this. It's actually, this is an antenna. It's an antenna and a receiver is what this amounts to. Okay, so it's sending a signal out. If it detects cotton, it sends the signal back, and then it sends it to the box, detection. That's how it works.
So then again, knowing that we have a very high BMI patient, maybe they're 4'6" and 400 pounds, so they are going to be thick. So technically, to be safest, we should be using the mat and the wand on those biggest of patients.
Right. So what I would recommend, the company doesn't necessarily make recommendations to put into policy, but I can tell you what other people do. Some hospitals will say if a patient has a BMI of 35 or higher, 50 or higher, whatever that threshold is that you guys decide to put into your policy, when the patient hits that threshold or above, we're going to use both the mat, if the mat is used for that procedure, and the wand. That belt and suspenders approach I mentioned earlier.
We had this system like over a year ago. We stopped using the mat. Why did we stop using the mat?
It was wrong with the blood and the water and all that stuff.
The older version of the mat, we found many times after uses became porous, fluid got inside, so we were sending mats in, sometimes they would be replaced, sometimes it would be, well, we think you damaged it, so it's your loss. So at that point, we kind of stopped replacing the mats. newest version, you know, company said, better material, it is more fluid resistant. So we did then go ahead and purchase 13 mats. So we do have, and actually I think we might have gotten, I think more than 13, we've got extra. So we do have them available for all rooms.
You bring up a really good point. You're on a roll there. So the mats, well, a couple things. The mats are different now, as you had mentioned. Okay, so the mats, I don't know if you remember the old ones, they were gel, they weighed about 15 pounds, they were super inconvenient to move around. The connection right here was right here. So basically where my arm would be if I were laying on the OR table. Really inconvenient, right? I don't know why they did that, but they did. So we changed that. So this is coming down more towards the patient's head or neck, actually, depending on how they're laying on it, right? So that's better. It's a lot lighter weight. It's more durable. The wiring inside that connects those 6 antennae is much more durable now as well, the insulation on them. So we made a whole bunch of changes to make that better. So I'm glad you guys have kind of reinstituted those. That makes a big, big difference. The other thing, too, is when this machine is on, okay, whether I'm using it right now, whether I have a confirmation code, whether anything's plugged in, okay, it makes no difference. The minute we turn this on, it calibrates the system to start your day or whenever you turn it on in that day, okay? The minute I plug something in, and if you remember right, red dot to red dot, just kind of like everybody else's equipment, don't twist it, just push it in. It's going to calibrate this and it turns green on the screen, right? That says it's okay. Same thing with the wand. Bayonet nut connector, push it in, twist and turn like a coax cable. It checks it, it turns green. Every second that that machine is on, whether I'm activating it to run a scan, whether I'm actually using it, okay, whether I'm scanning something right now or not, okay, makes no difference. Every 2 seconds, the machine is checking it, okay? The reason it does it every 2 seconds is if in the middle of a case, something happens, whatever it may be, okay? Somebody rolls over a cord, okay? I've never seen that happen, but I've heard stories. You know, somebody rolls over a cord, right? It happens. And something damages in the cord, the connection between the box and the mat, or the box and the wand, is now compromised. Mat error. Wand error. It's going to give you, and it's going to turn red, it's going to tell you right away. Or it might be yellow, depending on the error. It's going to tell you right away. And it'll say mat error, replace mat. And that's kind of what you were alluding to earlier. You get a mat error in the middle of a case, what do you do?
Unplug it.
Use the wand, right, exactly. You always, always, always have the wand. Now, let's say there's a wand error for whatever reason. Is the patient laying on the wand? No. Can you say, hey, can somebody go grab me another wand? And I just do this and I get rid of this? Yeah. I would guess, last time I was here, I think the biomed guys had a whole bunch of them in the biomed department even too. So I know there's extras laying around somewhere. Okay. So, if you get an error code, I know I've heard troubleshooting, you guys have unplug, replug. That's always a good first step. I've heard power the machine down, turn it back on. Another good idea. It's a computer, in essence, so let it turn off, wait 10 seconds, boot it back up. That can sometimes reset things. But if all else fails, just replace that item. Okay. You just change that, or is that always been like that? You just changed. Oh, okay. Yeah, I don't remember that. I just sent this to Tracy, so you guys actually have a copy of this, and I don't know if you're going to post it or attach it or whatever, but you'll have this as a reference. We talked about low and slow, 2 to 3 seconds, 15 seconds total. This is just a chart that references it. And the question was here about lithotomy for the wand. It's all right there. Okay. So you're doing an elbow, you're doing a shoulder, you're doing a hip, you're doing a knee, wand. Okay. What are the questions?
For Deb mostly, is there going to be like a standard workflow for like when we're going to be scanning for like joints where we need to introduce the wand sterilely to the field, or is this?
Yes, Tracy, Christine, Jane, we have been picking apart our count policy recently, so yes, there will be, you know, you do this and when.
So are we just going to continue the way we have been until that's released? Or?
As of today, again, recommendations are that we scan the incision, you know, once we've done the count. It means we're gonna have to make those sterile sleeves readily available. Obviously, especially the ortho-neuro guys are not going to, you know, allow.
Can you guys like send them emails or like put something up in the doctor's lounge so it's not like a big surprise to
Surgical
everybody?
section is when next month now, so, but
We
we
can
can,
put something in the lounge and
Yeah.
I'll have some type of memo to send to their emails.
Well,
Yes.
So if we're gonna do it sterile on the field, is it gonna be the tech that's responsible for scanning then? Because the nurse obviously can't if she's not sterile. And the doctor isn't gonna scan.
well, but again, you know, you,
Can you speak up so we can hear the question back here?
go ahead.
I was just asking, they said if they're gonna put the wand sterile on the field, it's gonna be the tech's responsibility to do the scanning, because the doctor sure as heck isn't gonna do it. And the nurse isn't sterile, so.
Correct.
That sleeve, Scott, oh, I'm sorry, how long is that?
It is 12 feet.
Okay, so again, that gives plenty of room, you know, you get the wand in there, you know, I can have my arm inside that, you know, so, yeah.
Oh, okay. We're still gonna have to pull our mail out.
Is that a question for me or for Deb?
Oh, it's for Deb.
Okay.
Okay, yes.
So if you do like a Weisskopf case, who basically he kicks it out and closes it right away, you want me to drape sterilely and then you know what I mean? Like, how does that work out?
You know, I think what we should do in the interest of time today, please bring questions to Christine, Tracy, Jason, Jane, or myself. So again, we can get those addressed and determine what the best practice needs to be.
Just a quick one, if the incision is in a spot where you are on the mat, is it appropriate just to do the mat scan before skin is done, or do you have to do the wand?
If it's, actually, you don't have to use the wand unless you meet some of those criteria that you guys might consider putting in.
Without, you know, wand.
So if the mat is,
But
if
it's
that,
right here.
right, if that part of the body's not on the mat, number one. If the patient has met your, whatever your BMI threshold you guys may set,
Right.
really those are kind of the two key indicators whether you use it or not. But you do not,
If it's a regular case and the incision
Right.
is somewhere, it's okay to
Yeah.
just press the mat and not do the sterile wand.
right, exactly.
Here's a wand cover if you want to show them how to put it on.
You guys have questions about putting the drape on? Should we go through it or? Go through it? You okay that I open it?
Yes.
As you guys remember, when we have this new system, I don't know how long it has been brought to us, but we started by having all this drape come up on our case card, and we have to open the field and scan it before we start closing. There was some resistance from the surgeons, but it slows them down. But the thing is, as long as we do our manual count properly, we just have to be focused much more on the belly cases where mostly of the viscous occur. So we have these mats, and like what your question or your question about when you want to do it. If you want to do it before they close, you have to remove all your gray bands or your naps away, because it's so sensitive that even just from here, it will detect it.
Again, let's please not get into processes today. You know, everybody has the best intentions. You know, you say play closer attention. I'm going to quote a very wise man whose name, unfortunately, I can't remember. To err is human. Humans are going to make mistakes. In our best efforts, we are going at some point to make a mistake. The fact is now, we have had a retained object. There's no more leeway for lax processes. Doctors don't want to take 15 flippin' seconds to make sure their patient is safe. That day is done. That day is done. So, okay, Scott, can you show us how to drape, please?
So I've opened it, unfolded it rather. When you've got your arrows, you're pointing in the opposite direction of the arrows. This is always hard to show here. I'll probably open it up when I should. But you've got little hand marks, that's where your hands are going to go, obviously. And you're going to grab the wand. Okay. You're going to grab the wand. This. And you're going to pull.
Yeah, yeah.
There you go. And away we go. And then you've got your ties if you want to. And you can see we're covering the entire, almost the entire cord. So just like doing your Mayo stand, to an extent, just like doing your CR, very similar. Okay. All right, I know I've taken more time than I probably should, but I appreciate your questions, because I think that's really why we're here today, is make sure everybody's on the same page. So real quick review. What's 77%? The effectiveness of a manual count. 67%. The effectiveness of X-ray. 2 to 3 seconds, not minutes. 1, 2, 3. Okay. What about the number 2 to 3 with regards to inches? 2 to 3 inches away from your patient. 10 to 15 seconds total. The amount of a full wand scan, okay? 88% from the first question of the day. The number of times there's a retained item and you go back and you look at the chart and the count was entered as correct. Okay? Last question of the day, go for it.
Another number, what is the accuracy rate of the wand and the mat?
Great question. So, and the numbers I cite are all published studies. We have 6 peer-reviewed studies that are out there, and all the studies have stated that it's 100% sensitive and specific. Okay, I know you guys had a retained event, and we're trying to figure out what exactly happened. But in all the published studies, it is 100% sensitive, meaning if it's there, we find it. 100% specific. If it's not there, false positive is false negative. If it's not there, it is not there. We're validating that. Okay.
Okay.
That was the last question.
Ah, very good.
Is there like a protocol for like someone should be checking this every? I mean, like doing, making sure that it's functioning. Yes.
Okay, so remember, a lot of hospitals at Biomed will do an annual check on like video equipment, right? They'll put their sticker on it, basically validate the electronics are fine. Remember what we said earlier about every time this machine is on, it's checking the connection that the wand has to it, or the mat, and the box itself. Every 2 to 3 seconds, it's making sure that all those connections are correct. And if there's a problem, it tells you right away. So that's ongoing. That never stops, so to speak. That makes sense? Yeah. And then in addition to that, your biomed has to check the electronics in certain
Now I just feel better every once in a while, just checking. When I do have sponges on my sponge bag, just checking to make sure that it's gonna recognize.
Thank you for clarifying that, because you're absolutely right. If it increases your comfort level, and this is, a lot of hospitals do this. This is actually a really good idea. Go ahead and turn the wand on, and if you want, you don't have to drape it, of course, but before you start your procedure, if you want to get close to your tagged sponges and have it go off, go ahead and do that. If that makes you feel comfortable, and you know what it might do? It might remind you, hey, we got to use this thing before the end of the case too. That's always a reminder. Okay. Hold on real quick. Did you notice it took a couple of seconds before it went off?
Yeah.
So that's why 2 to 3 seconds change direction. That's why 10 to 15 seconds total. Because what we're doing, we actually, this E Plus that you can't see, but it says E Plus on the top, we updated the software in here recently. And it's sending the signal from the box to the wand back, box to the wand back, then it tells you. Okay? We want to make sure it's not other electronic components, video equipment, anesthesia machines, everything else that's electronic in the room. There's a lot of better shielding of all that equipment in the room so that interference doesn't occur. But we want to make sure that if it goes off, it's going off because of our product, not somebody else's signal. True last question.
Database yet that tracks and monitors retained items? Because at one time there wasn't, but there is now.
Yeah, and you know, the interesting thing about that, not to get too much into the weeds about it, but different states are requiring it, different states fine for it if you have one and things like that. So there's a lot of regulatory push behind all that. CMS holds back reimbursement, 1 to 3%, I forget the exact percentage, but if you have a retained event, some of that payment is held back. Okay, so you gotta kind of earn that money back, so it's a big deal. But yeah, it's definitely absolutely tracked. Anybody ever heard of leapfrog grades?
Yeah.
It shows up there too. Yeah. Okay. All right. That was truly the last question, right? Okay, I know you got a lot to do, so all right. Thank you guys very much. Thank you for using the system, and thank you for your participation. I really appreciate it.
Stay put. Jane, I know you've got a couple comments for the group.
All right, wait, Jane, real quick. We're gonna take notes on what he said today, add it to the PowerPoint, and we're gonna send it to everybody, so everybody has it.
Okay, did you go through the count? Okay. I know that we have been coming around and you are not using your Bagot systems, and we're getting a lot of attitude about it. It is in the policy. Failure to follow the policy, you will be written up. No more. We don't want the attitude, okay? This is patient safety. I can guarantee if one of your family members were on that table, you would be doing everything perfectly by the book to protect them. The patient on the table is someone else's family member. We should be doing the same thing. You shouldn't be giving attitude when someone comes in, a supervisor, Deb, Mary, whoever, and says, why aren't the sponges bagged? We don't need to do that. No, you do. We've just been caught. We've had another event happen. It's time to get serious, okay? People's lives depend on what we do. So please, use the system. The policy will be out hopefully by next staff meeting so we can go over it in detail. But the Bagot system, the counts, and the RF system. 3 ways to prevent something that should never happen from happening. Okay? All 3 work in conjunction. I need you to use those. Okay? I'm not asking. I'm telling you. If you don't use them, I'm sorry, we're going to have to follow disciplinary action. Okay, you heard Scott say, you know, people are being fined now. Money's being withheld. Serious stuff, okay? Group of very bright, smart people in this room. We just have to follow what we know we should be doing. Okay?
I think in situations like this, like we all care about the patient, and asking about a standard of workflow prior to instituting it is frustrating for us. That's why we have a lot of questions, because we want to do it correctly.
Right.
And, you know, we're supposed to use the sterile scanner today, but there's no previous.
We will get a standard work put together for you. That Amanda brings a perfect point up. We'll get that brought up. The bags, I know we have them. I don't know how many we have. So I'm going to be honest with you. I don't know how many we have. So I don't know that we can institute this today. We probably have to get more ordered.
Well, we asked just now, it was said that yes, use it today.
I don't, do you check and see how many bags we have?
I did not check, but I will.
You did, okay. So Rose will be in about 9 o'clock, so we'll find out then. What?
The small procedure room has none of that. So, I mean, if this is consistent, we want this to be everywhere, it's not.
And we'll get it there. But in the meanwhile,
But, I mean, you don't
while we work out the fine details, the important thing is your counts, the Bagot system, which I can guarantee, I had a comment that we had someone talk to just the other day that didn't seem to think we needed to use it, the Bagot system and the RF. And again, on the RF, it's the taking your time to scan the patient. Don't do this because you're not going to get it. Remember he said it's got to bounce and bounce and bounce and bounce. So, again, we'll get you the all clear. We got to check and see. I don't know how many of those. Tracy sent a message to Rose, but Rose, like I say, will be in about 9 o'clock today. So, okay?
If we do nothing else, can we just go over the correct way to use the Bagots? Because
Yes.
it's not
Take it away.
consistent?
Crust.
Yes, especially the labs.
Okay, so recommendations are to fill from the bottom to the top, horizontally, correct?
so this way. And it is recommended on the bags for the laps that you do snap the middle piece apart and only have 1 pack of laps per baggot container. Another recommendation is to make sure that the green tag is always facing out, so that's an automatic draw to your eye that you see all of them. You can definitely tell that it's an RFID sponge. And then obviously the loops on the laps, make sure those are facing outward so you can see them.
Thank you.
And ARN guidelines, we are supposed to line our kick buckets with clear bags now. So we have 2 cases in our office right now, so we gotta start filling our rooms with these. We have 2 cases to start. It won't last very long, we'll get more, but we gotta change the rooms up today. And then at the end, you can put them in a red bag.
I thought you couldn't put a regular bag inside of a red bag. I thought that was.
No.
You can't put a red bag inside of a regular bag.
I thought it was a regular one either.
No.
Okay, so
We
no
do
red
that.
bags inside red bags.
We do that with
Clear
our
we can.
self-saver stuff. We have a clear and a red.
But kick buckets are supposed to have these, they're the same size as the red ones, but they're clear, so.
And we should technically be leaving the sponges and stuff hanging until the patient leaves the room.
Yep, and you need to make sure everything's in there. At your final count, you have a final look by the team in the room, that
You know,
everything's visualized.
again, there's that comment, pause for the gauze, when you have got all your sponges loaded. You know, again, often surgeons out of the room before, you know, we have finally done the final closure, the final count, but the PA, the FA, you know, so those personnel, nurse scrub, again, things happen, you guys, a patient unexpectedly wakes up, you know, starts moving, nurse's attention is now to the patient, sometimes that scrub's attention also now has to go to the patient. Things, again, it's not a perfect world that we work in, live in, because we deal with humans. I know it's gonna be an instance where something's gonna happen. I've gotta get this patient out of the room, they need to get to recovery. Something has happened, those sponges aren't in the bag. As soon as that patient is underway, safe, secured, whoever is in that room then needs to get those bagged. They need to stay until the circulator, the first assist can come back and verify, yes, everything is in those bags. Okay, it probably is 8 o'clock. I'm not sure how accurate our clock is. Please, obviously, still more questions. Please bring those questions forward. We will make sure, you know, again, policy is covered, the questions are covered as soon as possible for you guys. Thank you, thank you, thank Jason, I don't know how to turn this off.
Everything's from the bottom.